Thank you. Now you have the last case that will be presented by our chairman, Professor Miguel Nobre Souza. Professor Miguel is an associate professor from the Federal University of Ceará. Miguel, go ahead.
Thanks, Marcellus. I will present a very short case, a different one, and I think we can discuss some other topics till now undiscussed. Where is the... Just a minute. Try to share screen. Share screen. It's okay now?
Yes, you need to find your presentation.
Yeah. Okay. Are you seeing the presentation?
Not yet.
Not yet.
So let's see. Share screen. Share screen.
You need to open your presentation first.
Yeah, it is open.
You shared the screen, but you did not open your presentation. So
Yeah,
please
it's open.
share the screen and again, and then open presentation.
I will close it and open again. Just quit PowerPoint. I'm opening it again.
Fernando, you are here?
No, you are not. Now you have not shared your screen. Please first share your screen, then open the presentation.
Yes,
We could share your screen.
correct. It's correct. First, share screen, and then.
Yeah. Share the screen, and let's see. It is not here.
Change the option in the share screen. To
Yes, I have changed.
Change to window janela do aplicativo. Change.
Please, Fernando.
Yes.
Help.
I am at janela do aplicativo. The problem is that it doesn't show. Let's try.
Yeah, you have shared your screen. Open the presentation.
The presentation is open, but you can't see, yeah?
No.
No, presentation you have not opened, it seems. It seems you have not opened the presentation.
Você abriu a tela do StreamYard. Para essa apresentação.
PowerPoint?
Não, para a apresentação do StreamYard.
Ok.
Para de compartilhar a tela.
Let's go there. Parei o compartilhamento.
Isso. Entra de novo no compartilhamento.
Eu já fiz isso. Só se sair.
E compartilha a tela inteira, não compartilha o aplicativo.
Tá. Share screen, tela inteira.
Isso.
Ok.
Tem 3 abas.
Ok. And now?
Aí sim, ok.
It's okay now. Go ahead, Miguel.
Thanks, Fernando. Well, sorry for the delay. I will present an esophageal dysphagia patient associated with mild myopathy. It's a very simple case, a very rapid case. We have some relevant clinical facts. In February last year, she had GERD and was submitted to an anti-reflux surgery. Well, after the surgery, she had mild and short duration dysphagia. It was not a problem at all. In August last year, there was GERD recurrence and she needed PPI continuously. This year, on 9 March, and she had a surgery for varicose veins. And 1 week later, she began 1 week of fever, 2 weeks of headache, muscle pain, and adenomia. Her serology was positive for COVID-19. Well, she stayed there till July this year, when we could have some investigations about her complaints that at that time, July this year, was diminished proximal muscle strength that disturbed her for some household tasks, esophageal dysphagia, mainly for solids. That's why she came to us. She had no weight loss. Her body mass index was 25. She had some relevant clinical past conditions, a mild but stable multiple sclerosis, needing no treatment, and carpal tunnel syndrome. She took an electroneuromyography in 2019. Well, the diagnosis was only a localized neuropathy due to carpal tunnel syndrome. And this year, in June, and the diagnosis was proximal myopathy and carpal tunnel syndrome. Her brain MRI this year had no new findings relative to previous ones. An upper gastrointestinal endoscopy, June this year, showed mild esophagitis, grade A, a 4 centimeter hyperhernia, and no film duplication was seen. This high-resolution manometry was performed before fundoplication in February 2019. Well, nothing special except for the type 3A gastroesophageal junction. And the esophageal body motility was pretty normal. This year, in July, high-resolution manometry, it was really different. We couldn't see esophageal contractions in the proximal esophagus. Well, the gastroesophageal junction was the same. The fundoplication was completely absent. And just to make it some more quantitative, a kind of proximal CI, taking only the 4 centimeters of the proximal esophagus, resulted in 0 in this high-resolution manometry in all deglutitions. It was small in the previous one, ranging from 0 to almost 60. Well, this kind of, you can see here, also it's important to say, you may think there is a hypotensive UES sphincter here. In fact, there is not. During the same examination, you could see a pretty nice upper esophageal sphincter here. Probably this was due to some dislocation of the manometry catheter in this position. Let's review that swallowing function is very different from mouth to the distal esophagus. There is a skeletal muscle that is responsible for the initial phases of swallowing. And the mechanisms associated with dysphagia during these initial phases are a reduced pharyngeal contractility, a cricopharyngeal dysfunction, a reduced elevation of the larynx, and also proximal esophageal motility. The proximal esophagus typically going down to the aorta is mainly composed of skeletal muscles. That pattern is really different from a very intense manometry pattern during to another disease that that causes dysfunction to the lower third or lower 2/3 of the esophageal muscle. I'm talking about systemic sclerosis. Even in this situation, you can see pretty nice contraction in the few centimeters of the skeletal muscle esophagus. This type of contractions you couldn't see in our case. So that's it. I'm open for questions and comments. Okay. Okay. Marcellus?
Thank you for your case. I
Oh.
would like to know if Dr. Ghoshal could discuss this association between the COVID-19 and the distinction of esophageal motility. What is your opinion, Professor Ghoshal?
Only thing is, I'll ask a question. You said that the antibody to COVID-19 was positive, but did the patient also have an RT-PCR test?
PCR?
Yes.
No PCR, only serology. Serology and feverish and clinical setting.
Yeah, only thing is that since RT-PCR was not done, we don't know when did the patient actually get COVID-19. Because presence of antibody means there is a prior exposure, and the prior exposure might have led to COVID-19 or coronavirus associated disease, or it may be just an asymptomatic carriage. Now, but obviously it led to exposure, it led to infection. Now, about what are the gastrointestinal consequences of COVID-19? See, what happens is COVID-19, 10 to 20% patient can have GI symptom. And the GI symptom can be nausea, can be vomiting, can be abdominal pain, diarrhea, even constipation, and abdominal discomfort. 10 to 20% patient have. But usually these are short lasting. What happens is we hypothesized just recently, the paper came in PubMed that COVID-19 may lead to long-term gastrointestinal consequences and in the form of functional dyspepsia, in the form of irritable bowel syndrome, because this is like post-COVID-19 FGID. And we have compiled some evidences, and just today it came in the red journal in the red section. But as far as COVID-19 and motility disorders are concerned, there are hardly any data. There is hardly any data. In fact, I remember we described one patient. The patient has had varicella zoster, and following varicella zoster, patient developed achalasia-like esophageal pathophysiology, along with severe gastroparesis. And after a few months, patient obviously recovered from varicella zoster, and the motility abnormality also markedly improved. And this case we published in Journal of Neurogastroenterology Motility. So what I'm saying is, can COVID-19 lead to neuropathy-like situation affecting esophagus or the GI tract like pseudo obstruction? Nobody really knows. Just recently, we got a paper submitted to our journal, that is Indian Journal of Gastroenterology. This is a single case report
Do you want to discuss the comments of Professor Ghoshal?
Oh yes, for sure. We cannot say that COVID is the cause of this proximal esophageal kind of myopathy, if there is a myopathy. It's just an association. But we have 2 points that, well, turns it a little bit more possible for a real cause and effect association. One is that, well, there is no PCR, but there is an IgM serology positive. And also, there is a new onset peripheral neuropathy documented by electroneuromyography concomitant with dysphagia. Also, the patient had dysphagia. And at last, the patient is better. She has no more dysphagia. Unfortunately, she didn't agree to take another manometry, at least till now. That's it.
Yes, thank you. We have a question from Carlos Rica. I would like Daniel could answer the question. It is possible to use the magnetic ring in this type of the patient with regurgitation and GERD, or is your opinion, Daniel?
But this is not related to the case of Miguel, right?
No, that's not relevant. But you can discuss also the case.
Well, just first, I would like to say something about the case of Miguel. The fact that the UES was not affected, to me, makes it more difficult that the proximal skeletal muscle is involved. They are a very similar and anatomical, very close structures and a very similar neural regulation. So I must say that only the striated esophageal muscle without the UES affection, to me, is very difficult to understand. And I agree with Professor Ghoshal that maybe the problem is more a smooth muscle regulation involving the dysphagia rather than the hypomotility more proximal.
Okay.
Concerning the question of use of the LINX in patients with regurgitation, I think that the LINX is a very interesting device. It is used now in patients with refractory GERD with some success. The indication of LINX in patients with hiatus hernia is a problem. So if the patient has regurgitation in the context of a hiatus hernia, LINX is not very much recommended.
It's important to know if the regurgitation is not the regurgitation. No, Professor Daniel. It is a different condition that the rumination could be expressed as the regurgitation. It's very important because the treatment of regurgitation could not be using rings. is a very important point, in my opinion.
Say, I am not going to treat a ruminator with a lynx. No way.
Yes, but the diagnosis is not so simple.
Of course, of course, of course.
Miguel, could you now you can take the section.
Okay, just one more comment about Carla's case. I don't know if, in mild case, probably weight loss might benefit and possibly control reflux, since the mechanisms of reflux in obese patients, the main mechanisms is an elevated and high intra-abdominal pressure, but just mild cases. Well,
Can I say something more about that? These patients have bile reflux together with acid, and 40 years of acidic bile reflux in a young person is very dangerous.
sure.
What I
Very dangerous. Yeah, yeah. Yeah. Marcellus, can I say something about the Miguel
Sure.
case? This case is very interesting. It's a peristalsis, fragmented peristalsis by the Chicago classification, and we don't know what it means, fragmented peristalsis. And the question is exactly this. This is fragmented by a problem in the proximal or in the mid esophagus. So it's a challenge to help this patient. What you think to do to solve the dysphagia of this patient, or suggest?
Well, yeah, this case, it was really easy because dysphagia disappeared spontaneously. So the patient has no problem now. Okay.
Okay.
In cases of severe myopathy, like dermatomyocytes or polymyocytes, it's really difficult. You have to treat the baseline disease. And, well, probably you'll get around treating GERD, not the motility problem of the esophagus, if the patient have GERD. So that's it.
Yeah, I have a comment here. You see, I agree with Professor Daniel that this is not a skeletal muscle disease. This is a smooth muscle disease. So skeletal muscle, in fact, in upper esophagus, you had beautiful contractility. And if somebody has skeletal muscle disease, you will have symptoms which would be different. It will be more of a transfer dysphagia rather than esophageal dysphagia. This patient probably had esophageal dysphagia. Also, if you look at the causes of skeletal muscle disease, this will manifest with many other associations. Like typically neurological patient have skeletal muscle disease. We know that myasthenia gravis can have skeletal muscle disease. There, if you keep on taking multiple swallows, as you see, the later swallows will be having more hypomotility than the earlier swallows, which is typical of myasthenia. So it is smooth muscle disease. Now, what we know is that if somebody has really severe GERD, GERD leads to esophagitis, and the esophagitis can impair muscle contractility. So if you give a good PPI, or rather if you give a good dose of PPI, improve esophagitis, sometime muscle contractility may increase. Now, second thing is that you have very limited option really to increase the function of the esophageal muscle. Now, we found, this is an anecdotal experience, we did not publish it, but there are literature, but scanty literature. If you give pyridostigmine, actually this patient improve. And pyridostigmine neurologists use quite a bit. And what happens is pyridostigmine one option. Yantac showed that other drugs such as mirtazapine, and even he showed there are some studies with tegaserod that these improve esophageal motility as well. So either by serotonergic mechanism or by cholinergic mechanism, you can improve motility. And obviously there will be other option, like a patient has to eat in the sitting posture rather than standing posture, and all those lifestyle things will be useful. So what happens is you have very limited option to improve the esophageal smooth muscle function. So I would say pyridostigmine, other drugs that I mentioned, and then treating esophagitis if it is there with a good acid suppression.
Okay, thanks, Professor Ghoshal. Yes, anybody else to comment? So we're coming to our end. That's it. Well, once again, I would like to thank Professor Uday Ghoshal. I hope we can meet again in the near future, online or not online. Professor Daniel Sifrim, we miss you very much. Okay, and thanks again. Professor Ricardo Brandt, we also miss you very much. Carla, thank you very much for coming. Gabriela Bueno, thank you so much for coming. Marcelos, see you
later.
Monday. Monday. Okay.
Bye-bye to all of you. Bye-bye.
Bye-bye. Bye-bye. Thank you very much.
Bye-bye.
Bye-bye.
Bye.